Welcome to the award-winning AUA Leadership and Business Podcast, an official podcast of the American Urological Association.
Welcome to the AUA Business Podcast, where urologic professionals experience the practical applications of business acumen essential for success in today's dynamic professional landscape. I'm Steve Riggs, and on today's episode, we will be discussing philanthropy and digging into how it really works. We're fortunate on today's episode to have Eric Sklut join us. Eric is a native of Charlotte, North Carolina. He's a business owner and a philanthropist. He and his wife, Lori, oversee their family foundation and provide grants for various causes in local, regional, and national areas. He is going to be an awesome guest today on this topic, and I'm excited to have him. He has both raised money, contributed, and so I think his perspective is really going to be engaging and informative to our listeners. So, Eric, welcome.
Thank you, Steve.
So I'd like to start off maybe a little bit broadly and get into just some basics around philanthropy or some concepts. How did you get involved in philanthropy? And I think as we get into that, can you maybe help unpack some of the misconceptions?
Sure. My wife, Lori, and I started our family foundation over 30 years ago at the urging of our CPA. And he thought it would be a great idea. We already were contributing to various nonprofits. And he thought heading in this direction would be fruitful for both the agencies we get involved with and also from tax purposes. So we started our foundation then and began to carve out our mission statements, primarily healthcare, faith-based initiatives, education, and human service agencies. And as a result of that, we became connected with many of those institutions in a deeper way. As far as common misconceptions, I think there probably are a lot of organizations that believe if they put the story out there, the donors will just fall in line. And for us, we do a deep dive on any request. We do receive numerous miscellaneous requests, but we're married to 30 to 40 different nonprofits in the region, and they know we expect metrics. We expect their mission statement to know how effective they are with that mission statement, and what audience are they primarily helping. And if we contribute dollars, we want to know how many heads are impacted by each dollar. So it's not a given that and this may be a misconception as well, that just because we contributed last year doesn't mean we're just automatically going to write checks every year. We expect them to reach out, give us a report, some idea of how they're doing, what's planned, expanded customer base, so to speak, and then we make decisions quarterly to contribute, continue, or pull back.
So I think I'd like to pick up just one thing you said there, and as we move through this, is it fair to assume, or maybe ignorantly, some of our listeners, or at least me, might be assuming, I don't know that a lot of people that donate, or specifically for you, think of it as a one and done, or do you say like, hey, are you thinking often this is the only gift I'm going to make? Or are you really trying to engage, see, and does the individual or the provider, or in this case, I guess, urology, should they be thinking, hey, cultivating this relationship after I maybe got a first gift may not be the end of it, and the donor doesn't always expect it to be the end of it? Do you understand what I'm asking here?
Absolutely. I think a lot is based on the relationship. For us, we found a handful of agencies that we've gotten to know better than others. Deep dives year after year. We've gotten to know their leadership. We know what they do, where they do it, who they cater to. In some cases, we volunteer. We just go there and see, what do the volunteers do? What does the staff do? Not so much that it's a given, but I think in most cases, we're being asked for multi-year contributions towards a final goal. whatever the number is that they've requested or we've decided upon, that may take 5 years to pay out. And many capital gifts and even large endowment gifts, most organizations receiving those from philanthropists expect that there won't be a check all at once for all of it. They'll be 3 to 5 years out, paid out over time. Beyond that, there are organizations that do have emergencies. And in fact, right now, timely enough, we support one of the larger hunger-related organizations in Charlotte. And even though we've contributed to a multi-year gift for a capital campaign that built their new headquarters, we reached out to them when the government shutdown began to impact food insecurity and who they serve. They are running an emergency campaign. So in addition to our capital campaign gift that is still being paid, we reached out with another substantial gift to get them through this emergency campaign.
So do philanthropists talk to each other? I mean, is it like a group you're trying to, I hear this often, and this may be a misconception. Is this like a group you're trying to crack the code on and become part of that network?
Steve, there are a lot of people where we are that their names are on buildings or they're in the newspaper constantly for the great things they do to benefit the community. So even though I'll say it's a relatively small circle who are involved in large gift philanthropy, many of us know one another primarily because we are asking each other to be part of one campaign or another. But it's less likely, in my opinion, that I'm at a cocktail party and I run into someone who is another donor at a similar level, and we start discussing different organizations or philanthropy in general. Could be if when I wear my fundraising hat and I help these agencies raise money, I may have an ulterior motive to going to that party and know that I may connect a few people who I already know, but I'd rather speak with them in person.
And I think you said this to me before, and I just want to pick up on it a little bit because I thought you led in a little bit to this. As someone who might be seeking funding for good causes in healthcare, as a urologist or a provider, the individual person you may be talking, that may not be their quote cup of tea, but the relationship that you create, they may know somebody whose cup of tea that is. Did I say that correctly?
Absolutely. I think you kind of hit the nail on the head when it comes to being a fundraiser, that you want to first approach those you know have some interest or do that sort of thing, make contributions. Secondly, if the conversation leads towards the ultimate goal of an ask and they let you know they're interested but not in a position at that time, the follow-up question is, who else do you think would be? And it's a very common part of a conversation, and it should roll off the tongue of anyone, whether it's a doctor speaking with a grateful patient or some other discussion socially outside of healthcare.
Why do you see philanthropy as so important? I mean, maybe what's its power when you think about it beyond maybe the obvious or the folks that are trying to receive the gift? From your perspective, why is philanthropy so powerful?
Well, I think in many cases it moves the needle in a way that nothing else can. Organizations that, particularly nonprofits that have tight budgets, their audience or customer base is expanding on a year-by-year basis. They're strapped and they will operate within that budget, but they're not about to be in a position to go hire additional leadership. In other cases, it could be just the volume of need. And today, unfortunately, the need is greater. Every day we turn around, there's another emergency. But I think with philanthropy, you've got an alternative to dipping into government funds, whether it's city, county, national organizations that fund various causes. And this is very clear right now that you see once the faucet cuts off, these organizations are going to die. We hope that won't happen. It won't go that far. But if people have wealth and they've planned this accordingly and have a desire to be involved, the likelihood is by making that contribution, both time and money, will move that needle. And that's what Lori and I try to do with our philanthropy, is to make changes. And sometimes that means we do a challenge match. Campaign exists and they're looking to increase the donor base. So if it's publicized that Eric and Lori gave X amount of dollars towards this campaign, oftentimes that will push the peer level philanthropists in the area to do the same, or get involved, or reach out and say, hey, what is this campaign all about? I want to be involved.
What makes a good philanthropic team? And I think in that kind of segment, I want to think about, like, I guess at a basic level, what does the donor want or should expect? What should you expect the donor to expect back?
For us, it's those metrics. If we, obviously, we'll be thanked for our gift and we'll proceed. We're not micromanagers. So once we believe in an organization, its leadership and its mission, and our team is confident that the numbers we're looking at are accurate and honest, then we proceed. And if we commit for 3 to 5 years for whatever the dollars are, we're not expecting to call them every month and check in, but we are expecting a once a year, on average, once a year meeting and an update. If they run into a problem, we want to be notified of it. If they're unable to use the funds for the purpose intended, we expect a phone call. Would you consider if we, change tracks with this? Sometimes we will be happy to do that. Other times we'll get our team together to decide if that's within our mission. In terms of the team and what the donor expects, we do expect to have these relationships. So it's not, hey, somebody calls us and we write a check and it's the end of the story. A phone call doesn't do it. So we put eyes on it. We do have a handful of people around the table who will get us the numbers and get us the information we need.
So just framing the physician-patient, doctor-patient relationship, kind of in that perspective, do you expect the provider to be involved?
On the healthcare front, since that is a larger segment of our philanthropy, if the provider is not involved, we're likely not involved. So we're wanting to meet everyone in the chain of command if necessary, but primarily we want to know where the need is, who needs it, and we want to meet that person. It's always best to be able to put a face with it and not just have an executive summary presented and a budget and a request for funds. As you likely know, in most healthcare systems, there is an entity, whether it's a foundation or other, but it's an entity that is charged with the continual fundraising efforts of that system. Lori and I have been involved with that one system where you are, and we've contributed in various ways over the last 20 plus years. So yes, we do know the doctors, we do know the nurses, and we know the administrative and executive staff. And we attend a number of events during the year to celebrate them. And those are great times to reconnect with people, both at the provider level and those in the fundraising world and executive level who are removed from the direct need. I hope that answers the question, but I think it's the ultimate answer is, if the person in need, the organization, leadership, and the actual provider of services is not part of the discussion, then to us it's not as relevant.
Yeah, which makes me appreciate the need at some level, and I think most of our audiences will resonate from the position they're coming in, is the engagement with the philanthropic team at your organization and your perspective as an individual provider, and understanding at minimum what is your role in that evaluation in that seeking, in that hope of gaining philanthropic support.
Exactly. You can't get a clear picture otherwise. So again, it's like someone selling you something. If, okay, what does the product look like? And they just describe it instead of show it to you.
Mm-hmm.
That's smoke and mirrors. So yes, we think it's critical.
I think leaning in a little bit of that from the provider perspective, I'd like to focus on that for a few minutes. What can physicians or providers do better about seeking support? I mean, I think at a basic level, what do they not realize / understand?
Well, I think from my personal experience, knowing the provider and having a relationship, not just, hey, Eric, you're here, you're not well, what's wrong? But some continuity past that of a connection of sorts, a brief conversation about whether it's family or what have you been up to or your work world, et cetera. But I think in the healthcare world, it is a little difficult to say, yeah, a doctor-patient relationship in a clinic setting might be a challenge for the medical provider, the doctor, to say to a patient, hey, we're doing this capital campaign and I've taken great care of you. Would you consider, that kind of conversation is probably going to go off the rails, and it may cross the line. In most cases that I'm aware of, and those, in fact, personally, it's been outside of the facility, but directly between us as donors and the provider. It may be at one of these events or a social setting. And I think that kind of eases the tension just a bit and allows for a free-flowing conversation. Lori and I had a conversation 2 days ago with a large healthcare system outside of Charlotte, and they're embarking on something that's never been done in the region, and it's unique. It's quite large, and visually getting to see both the plans and what this will be and how it will function, along with 2 medical professionals who are leading the effort, was a way for us to crystallize. Is this something real? Is it something that falls into our mission? Are we likely going to participate? And this was just 90 minutes, but it was around a table over lunch and a very dynamic, moving discussion on healthcare in general and this specific project. So I think the more a healthcare provider can move beyond the clinic room and into a social setting, the likelihood is they will connect with a donor. We've discussed with other healthcare professionals the whole idea of the grateful patient. Is there a brochure? Is there, hey, if that patient says to their doctor how much they appreciate, how much they enjoy the setting and the success that they've had with that doctor, that opens the door a little bit for a brief discussion, maybe in the clinic room. But in all honesty, I think the base conversation on philanthropy comes outside of that. It has to be in a social setting.
So if I heard you to unpack this, and maybe just 2 statements, is one, the physician needs to be aware, like listen for some of the clues, right? And so that requires us to not only take care of the patient for their condition, but also be aware in that interaction, in that treatment course, about picking up on things the patient might articulate that would suggest their interest in being a donor and or means. And then I think the other thing is the physicians and patients have this unique physician-patient relationship that evolves, and you can parlay that relationship into a new relationship, which transcends, I guess, or is different than the I'm taking care of you. Did I unpack that in those 2 concepts?
Very clearly. I think not being a medical school graduate, I would say how likely is it that in med school they teach you fundraising 101? And there's not a class for that, no matter med school or not. But what I've learned over the years of fundraising and being a donor is that if you can't sense those signals and know how to engage, then it could be that foundation or the fundraising entity in your healthcare system has the tools to work with you and work with the entire team, so they understand medical care is first, patient care, and then these other issues. How do you broach the subject? What do you look for? Those kind of things. And look, in and out of medicine, not everybody's comfortable raising money or asking, even though it's a great cause. So I think it's critical that they either get some sort of training, get comfortable as a team in a discussion. Another idea, because not everybody knows who the philanthropist is walking in the door with a cold or a sore throat or some tragic disease, having a dialogue among your peers in a clinic setting, whether it's a staff meeting or otherwise, to toss a few names around without violating HIPAA law and just say, hey, I've seen these names on a couple of buildings and I saw this person as a patient. Does anyone know them? If someone in the room raises their hand, that maybe they play golf with them, maybe they're connected some other way, but that's the way the door can be opened. And I think it's a tool that some people know to use. It's a great tool. If it's not being used, it should be.
But at just an entry level concept, the physician just, again, being aware, but also just identifying, right? And even at minimum, I think I hear you saying, if you're uncomfortable, quote, asking or engaging outside of the clinic setting, that you could alert your philanthropic team, which most people are going to have access to, but it's just possibly alerting them and being engaged in the process, being desired to be an active member, even when that won't necessarily require you, and oftentimes if you won't require you being part of the ask.
Exactly. I think in any setting, healthcare or outside healthcare, the key is that it is a responsibility of everyone under that umbrella to know that, okay, we've got a beautiful building and we see a great patient load and we're generating revenues and getting paid. But beyond that, now we hear there's this $20 million expansion or $50 million building and so forth. Everyone has to play a role. And Lori and I saw this when the local cancer center was being built, that in order to get the best cancer care until recently, we had to leave town. And someone tells the story of a relative, a close friend or otherwise, who had a debilitating diagnosis of cancer and could not get local treatment and had to go hundreds of miles away, if not further, for treatment. And you hear these stories often enough, and then you say, well, wow, we've got an opportunity here, and it's right in our backyard. So we as philanthropists want to be involved in that. You as a healthcare provider should want to be involved in that. And it's the dream, it's the magic of the dream that brings that together. So everybody has to play a role. It's not just taking care of the patients and dealing with all the insurance hassles and paperwork and whatnot. It's dedicating a small fraction of time to those conversations.
I love that. I love that concept. It just highlights what I believe is so important about this topic. And I just want to reiterate that again. It is the responsibility, suggesting the responsibility of the provider and understanding that not-for-profit and the groups that are doing social good cannot carry out their mission in their entirety without philanthropic support. And we are all responsible for helping to cultivate that.
I agree. I think it's a newer concept. If you look back 15 years or beyond, 99% of those dollars were raised by that separate entity. Mm-hmm. They were in charge of knowing who's who in the community. But you, as a healthcare provider, know who's walking in the door and getting services. Just like I walk through your door, I've been involved with philanthropy, involved with your cancer center, and cutting ribbons and enjoying the excitement of being able to provide that service to so many patients in the region. And then here I show up and I need your services. And it was a little strange for me, but we connected on the first visit, and you provided absolute miraculous surgery. I'm healthy to date, and just having that one-on-one and seeing what goes on there made me appreciate it even more, which is what brought the question, what do you need? So I'm a grateful patient, and I reached out. You did not. And I don't fault you for that, but it was, hey, what do you need up here? What's needed? It's a phenomenal facility, and it's relatively new. So now you take that to where we are today. If the doctors don't begin to speak up and take a minute to realize who their patient load, who's on their patient list, they could be missing some significant windfalls that end up creating long-term relationships with philanthropy. So for Lori and I, it was just an easy one when, we asked you for bullet points. What do you need? And we got right behind it and said, okay, we're jumping into this, see if we can help you provide services to more patients in a more efficient way.
Do you have advice for people who, I guess, physicians who want to be more active in the process? What advice would you give them if they're pitching, if they're trying to articulate a particular vision? What nuggets of advice can you give to them from your perspective?
Well, first, I think they have to have a clear picture of what it is they're pushing. What's the picture? What is the project? What is the building? What are the services? What's new? And they can gather most of that pretty easily. There are details from an administrative standpoint of the size of the project, the budget scope, the timeframes, et cetera, but that's minutia. And I think the more clear they can hit the high points at 30,000 feet, and we call it typically in our world the elevator speech. Be prepared with a small Post-it note for 3 or 4 killer bullets of the story. You have 90 seconds on the elevator to tell your story. Grab them with those bullets. If there's interest, they'll know. It's an easy thing. Unless you're unable to detect social cues, you would know immediately that that person shrugs and walks away, or they want to know more. Hey, let's grab lunch, or meet me after work, and let's have another call on this. So I think that's critical. But if the docs are reluctant to some degree, there may need to be a push, again, with a team meeting, all the docs in the room, 20, 30 minutes, bring someone in from the foundation, bring someone on the fundraising side in the room to talk about what they see as their role. And again, look, you guys are spending every waking minute thinking about patient care and how to solve these issues. So carving out a few extra minutes is not easy. I get that. But you have time off periodically. That's the time you can think about these things and have these meetings. So to me, I think that's a critical part, to get those docs geared up, amped up, however you want to say it, to be able to make the pitch.
Yeah, I think the other thing that's resonating with me, and I think you're alluding to this to some degree, is there is obviously a lot of people who want to participate as donors, and they are going to participate with or without you, more likely than not. And you are just you do have to make an effort to get on their radar as a potential option for them. Yes?
Absolutely.
Yeah.
Cracking the door, it's not just for you cracking the door to a donor, but for me cracking the door when I'm fundraising. There have been campaigns I was involved in that took 3 years, 2.5, easy, and should have taken 2. When you're competing for philanthropic dollars, as a doc and you're pitching the greatest project ever in the history of healthcare in your region, and you're competing against 6 or 8 other large campaigns in your region or city, that's a bigger challenge than most. And for me as a fundraiser running a campaign, I'm competing with these 6 or 8 others every time I have a conversation with a donor. And that is the same problem. So, you're stretching the dollar as far as you can. Some donors, deep pocketed donors who are interested, are already committed for a multitude of years for millions of dollars to these other campaigns. So they're reluctant to commit to something that you're asking for, whether it's you or me. So knowing that, and these are just the hurdles of fundraising, but I think as you begin to develop some skill in having the conversation and getting comfortable with it, could be on a golf course, but the bullet points, the elevator speech, focusing on those critical key things to engage someone that's the best thing anyone can do in your world. And again, I know it's not easy because it's kind of outside the realm. You're not running a business and you could take 3 days off and go do community service. You're keeping people alive. And I'm thankful that the medical community here is as strong as it is, but by the same token, all of you in that world have to play the same role and be part of this story.
I think it's also too for the physician provider to realize this is about relationship, and that relationship may not bear fruit immediately, right? Whether the donors contributed or that is just not the right timing or they're not interested. But they also, the third kind of level in that I keep hearing you say is, but they might know someone else, right? And it's also getting uncomfortable with just trying to build those, I wouldn't say uncomfortable, getting more comfortable with building those relationships to make it easier. And really, I think for us, for providers to think of it as, I'm just relationship building, because I do sense that some of this may happen organically as you build trust with each other.
No question that the relationship I had with you through my course of treatment and surgery and back to health, it wasn't 10 years. It was a series of months. But then we started this conversation and I didn't know enough. So you were comfortable enough to tell me more. And we did a deep dive and got the details that were needed to make it clear so that our team could then come back and say, okay, let's look at this. Is this something we want to do? And is this something we can do? Within the healthcare piece, I think it could be as simple as asking the question to the patient, were you happy with the services provided? And this could be a survey. It could be anything. It could be that grateful patient brochure we've discussed. But asking a handful of those questions towards the end, knowing the patient as well, the patient had a reasonably good experience. Were you happy? Were there things we missed that we should improve on? And as they begin to provide feedback, that begins to crack the door even further. And you have this conversation. Hey, I heard you had some issues with this or with that. Would love to hear more about it. And if they're willing to talk, well, there you go. You've already started the dialogue and it's outside the clinic room. So to me, I think that's one easier way if they're reluctant to kind of make the sales pitch.
As we get down the home stretch here, talk to me a little bit about post-gift interaction. And I'm just framing it that way. After you receive the philanthropic donation, what's the etiquette? And I think you touched on this a little bit more, but I just want to close the loop on this. What's the etiquette for the recipients? Like, what should occur?
Yeah, in most cases for us with the nonprofits, education and healthcare are other facets of our mission. We normally receive a year-end or a once-a-year report on a fund if we've created endowments that are invested by that institution that show us where they are, what they've spent, where they expect it to be in the coming year, and what the purpose of the cash flow was from that fund, or this project that was capital in nature that we funded, the space is now finished or it's about to begin or so forth, just updates, no more than once a year. For those who kind of gloss over that step, it's not likely they're going to see much from us in the future. So we rarely reach out and say, hey, it's been 18 months, we haven't heard anything. If they haven't responded in some way, not in overreaching, effusive, thank you so much, et cetera, but just, hey, here's where we are, here's what's transpired in the past year. Then again, if they just miss that, then we probably know it's not for us down the road. For those who do respond and give us the metrics and a deep enough dive, that they're going to see us and they're going to hear from us, like this last piece where there's an emergency campaign and I just picked up the phone and said, hey, what do you need? And we made a commitment to this emergency fund.
Yeah.
So that's an organization we trust, we know, we communicate, we hear from them, but they don't badger us and we don't bother them with their functioning.
Yeah, it makes me appreciate the possibility and correctness of cultivating that relationship and being good stewards of the, of the philanthropic funds. And while that in itself should be good enough, it may create other opportunities or other repeat gifts or needs when you need it. I really appreciate those comments.
Sure. Happy donors. You definitely want those as much as you want happy patients.
Yeah. Any other final comments?
Nothing in particular that we haven't discussed. I think knowing that how interested you've been with this topic, and hopefully that spills out to the medical community at large, it may really give a boost to those on the fundraising side of healthcare, where they realize, okay, we've got this army of soldiers here who are doing, miraculous things in healthcare, and they're the strength we're building on. Why not let them speak for themselves? And I think you deserve that as much as you deserve the praise from patients who are happy. You get a call here and there of patients who aren't so happy, but for us, like most philanthropy, I think people have the funds, they have their mission and interests. So why not play into that? If they're not able to, they'll tell you.
Yeah. If you don't ask, you won't get.
You won't get. Exactly.
Thank you so much, Eric. Thanks for sharing your time and expertise with us today. And thank you to our audience for joining us on the AUA Leadership Business Podcast. Until next time, continue to learn, lead, excel, and chase the uncomfortable. We'll see you soon.
Make AUA Leadership in Business your go-to podcast.
Subscribe today by searching Leadership in Business on your favorite podcast app and enhance your leadership and business education needs. Until next time, continue to learn, lead, and excel.